Good evening. Welcome to San Mateo County Dental Society's second general membership meeting of the year. Looks like we got a great audience for tonight, and I want to thank you for all joining us. My name is Brad Hart. I'm your 2001 Zoom president of the San Mateo County Dental Society. Before we get started, I just want to review the usual rules we have to do about how we're going to run this meeting. All participants will be placed on mute. Our presenter will provide a presentation on updates on local anesthetic. And Tuesday I had a failure and had to send the patient home. So I'm going to listen acutely tonight. Tonight's presenter is Alan Budenz. Dr. Budenz is a professor in the Department of Biomedical Sciences and is vice chair of the Department of Diagnostic Sciences at the University of Pacific, Archer Dagoni School of Dentistry. Well, we've had a lot of linkage, I think, to UOP, and I'm getting grief from some of our members since I'm a UOP graduate. But he did receive his graduate degree in anatomy from UCLA and his dental degree at UCSF. Dr. Budenz has taught anatomy courses at the University of Pacific since 1984, which is real close because I graduated in 82, and has extensive experience in head and neck anatomy, dissection, nerve tract identification, and particular emphasis on local anesthetics, anesthesia. He has lectured nationally and internationally on local anesthesia, anatomy, oral medicine, oral diagnosis, and cardiology topics. Dr. Budenz has over 35 years of general practice experience in San Francisco, has served as clinical group practice administrator and chair of the Department of Diagnostic and Emergency Services, and is as a general dentistry clinical instructor at Pacific. Due to his background, Dr. Budenz was well qualified to combine basic anatomical instruction with practical clinical application for dentists and hygienists alike. And for 14 consecutive years, from 2005 to present, has been recognized as an annual leader of continuing education by the Dentistry Today. Please welcome Alan Budenz.
Great, thank you, Brad. I love all the overwhelming applause that I'm not hearing, but hey, that's wonderful. It's good to be with everybody this evening, and I hope to share some new thoughts and ideas about local anesthesia with you, and I hope that these will help you with not only the problem patients, but just with gaining more successful, more efficient, and certainly more comfortable anesthesia for your patients. Just a quick disclaimer, I have done some consulting work for Septodont, and they have sponsored some of my presentations over the years, but I am not an employee of Septodont or any other dental company. I do work for the University of Pacific Dental School, obviously, but the opinions in my presentations are strictly mine. They're based upon my reading, my use, and knowledge about these different products, but they're an opinion, so please take it as that. All right, we know that our patients, at least the normal patients, don't really like getting shots. You know, they're afraid of the needles. And so it's not surprising that patients rate painless injections as one of the very most important criteria in judging how much they like their dentist or their dental hygienist. In terms of, different things we can do, there's a lot of different ways that we can try to make the injections more comfortable for the patient. I'm not going to go through most of these things. To me, the most important thing is the bottom one, number 10 down there. It's having confidence in your knowledge about our anesthetic agents, how they work, and what are the proper delivery techniques to get the most out of them. The most not only for your patient's comfort, but also for your efficiency and for the profundity that we need in order to do good quality dental work. So I want to start just a little bit quickly about topical anesthetics. We know that topical anesthetics come in a lot of different formulations, you know, liquids and gels and sprays and so forth. Their penetration through the mucosa is pretty minimal, just a couple, 3 millimeters. But I am a big believer in topical anesthetics. Viscous lidocaine, this is an amide anesthetic, just like our injectable lidocaine. Our amide anesthetics do not penetrate through the oral mucosa very well. And this is why most of the topical anesthetics that we see, the benzocaine, tetracaine, lidocaine, hurricane, whatever, these are all ester formulations, which has a much better penetration through the oral mucosa. Now, another thing that we have available, and something I really love, are the compounded topicals, which are a mixture of an ester and an amide. And what these compounded topicals are doing, they're using an ester to more readily penetrate through the oral mucosa, and that ester drags in the amide anesthetic, and the amide anesthetic gives a much more profound topical anesthesia to a little bit deeper depth than what just a pure ester would give. So in terms of the compounded formulations, you can see what we have here is a mixture, for example, 10% lidocaine, 10% prilocaine, and then some ester, a little bit of tetracaine. Now, my personal favorite for the topical anesthetics is a no-brainer here. It's the last one here, the best topical ever. I mean, what would you want more than that? The best topical. I mean, my gosh, it's great marketing. Okay. Interesting thing about these compounded formulas, they're not regulated by the FDA whatsoever. And why this is, I don't really completely understand. So you want to make sure you're buying these things from a reputable company. I've got a sample bottle of some that I swear was made in somebody's garage, or maybe it was a byproduct of some meth lab or something. I really don't know where it came from. But the compounded formulas bought from a reputable dealer, I think, are very good. Couple things that are important, though, and this is from a publication in JADA, the American Dental Association Journal, is that you only need to use a very small amount, apply it for a minute to no more than a minute and a half, and then rinse the area off. And the reason that we say this is that there have been reports of tissue ischemia and tissue sloughing occurring if these compounded topicals are left on the tissue too long. So a little bit for a very brief time and then rinse it off, and they work really well. Another topical is Orachix, and I know a lot of people use Orachix. This is, again, this is a mixture of amide anesthetics, an EMLA formulation, if you will. This has a pretty rapid onset, has a good duration of action. It's put into the sulcus around the tooth. It's a blunt tip needle with a little side hole, just like an endodontic irrigator. It goes in as a liquid, but the body temperature turns it into a gel, so it stays right there in the sulcus, and it gives good topical anesthetic around the tooth. So for a patient who's a little bit squirmy with a cleaning, but they don't really need full-on injections all over the place, this is a really nice way to deliver topical anesthetic. Here's a quick chart here looking at our conventional topical anesthetics. We've got the ester here, we've got lidocaine, the amide. Lidocaine, Lidocaine's an interesting one. Lidocaine is the only one that's not approved by FDA in terms of conventional topicals, but Lidocaine's a great topical anesthetic. I like this stuff. Duration 30 to 60 minutes is awesome. And then you see down here Orachix with the 20-minute duration. Looking at the compounded topical formulations, again, none of these are approved by the FDA, and therefore they won't quote any hard and fast numbers. But most of these have a pretty fast onset. They say average 3 to 4 minutes, but I would say it's less than a minute. And duration tends to be about half an hour. So I think they're all quite good, and I highly recommend them. What I tell patients is that I'm going to put a little bit of topical anesthetic on the injection site here, just so you don't feel the tip of the needle as much when I give you the injection. And so, you know, part of it is to dull the feeling of the needle, yes, but part of it is also psychological, telling the patient all the things that you're doing to make this as easy and as comfortable for them as possible. And if they trust you, if they believe you, then psychologically, topical anesthetics do work. Now, they also work physiologically, but you know how important placebo effects and all this stuff are. So the psychological component is good as well. Diclone or diclonine is a product that was on the market for a good while and then disappeared. It's just recently been brought back onto the market by Septidont. Now, we've always been able to get it formulated from a compounding pharmacy as either a regular strength, a 0.5%, or 1% as a double strength. This is really popular, especially with dental hygienists. It's very easy to use. Just dilute a little bit, have the patient swish it around in their mouth, spit it out. It gives very good topical anesthesia for a good half an hour plus. It's a little bit slower on onset than Oracix, but this was a very popular topical, and I'm glad to see it back on the market. Okay, another thing for comfort of injections is how fast you give your injections. The ideal is to give your injections about a minute per cartridge of anesthetic solution. Now, I know, and forgive me if there's any oral surgeons out there in the audience, I've seen oral surgeons give injections just bam, 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 and it's like, wow, didn't know you could give it that fast, that many cartridges that in that short a time frame. But I have to look at it from the standpoint of, hey, oral surgeons are going to hurt the patient no matter what. The patient's going to be in pain post-operatively after getting a tooth pulled out or whatever the situation is. As a general dentist, I don't want my patients to feel pain at any point during or after the procedure. So I'm going to go a little more slowly, be a little more gentle with my patients, all right? You're probably all very well aware of computer-controlled anesthetic delivery devices. The wand, for example, or it's been sometimes called the single-tooth anesthesia system. The wand's been around for a couple of decades at least now, and there's some other newer players on the market as well. And the objective of these computer chip-controlled anesthetic delivery systems is very simply to deliver the anesthetic at a slow enough rate that it will be below the threshold of pain perception. That's all they're doing. And frankly, can you do the same thing with a hand syringe? Yes, you can. But can you do it as consistently? Probably not. So they are nice. Some people really love them. Some people just don't. They try them and get frustrated. It's not for everybody, but it works for a lot of people. So the wand, you can give any conventional injection that you want. They claim a little safer PDL injection, which I think is true because you can't over force it into the tissue, if you will. Couple things, I really like this hand piece. It's very small, less intimidating to the patient. Couple things I don't like though, the cartridge is not in front of your eyeballs. It's back here on the machine, and the anesthetic is connected to the machine by this big long tube here. When you deliver a full cartridge of anesthetic with the wand system, you lose about 0.4 of a cc in the tubing of the machine. So you're not delivering 1.8 cc's, you're delivering 1.4 cc's, which I'm not real happy about, to be honest with you. But it's a great machine, it does work. A newer product, the CalEject, it has different injection modes. A nice thing here is the cartridge is in front of you, and again, it's a very slim handpiece, less intimidating than your conventional handpiece. But like the wand, it is attached to the machine by tubing here. So it's not one of my favorite ones for that simple reason right there. Another one, this is a completely non-tube. It's battery powered, so just handheld. Again, it's got multiple injection modes and so forth. It's a very nice system. The only thing I don't like about this one is it's a little bit bulky, especially if you have a relatively small hand. The last one here is the DentaPen, and this is probably my favorite of the new bunch of machines here. It's much smaller. It fits any size hand, large or small. You can use it in a pen grasp, or you can use it in a conventional syringe grip, whichever way you prefer to do it. Very easy to operate. The cartridge is right there in front of your eyes, so you can see exactly what's going on. Very simple, very convenient, very easy to use. All right, what else is new in dental local anesthesia? You've probably all heard at some point about Kovinase, the intranasal spray delivery system. This is essentially an ester anesthetic with a little bit of a vasoconstrictor mixed in it. It's designed to give a unilateral regional nerve block to the maxilla, to the anterior maxilla, essentially from the second bicuspid forward to the midline, maybe a little fuzzy on either one of those extremes there. They originally advertised this as a sniff administration system, you know, no needle, non-invasive, completely painless, very easy to administer. You could give it to your patient to sniff this while they're out in the waiting room, getting ready for the appointment. Well, I think they figured out that that maybe wasn't a completely smart idea, and perhaps that the sniff labeling there had a little bit of drug culture connotation there. So they changed that to a spray administration type of system, which I think was a smart move here. So essentially what you're doing is you're spraying the anesthetic up into the nasal cavity, and it's being taken up into the maxillary sinus. So you give 2 sprays. The first spray, you give it, and then you wait 4 minutes and give a second spray, and then you wait 10 minutes. And what this does is it penetrates through the wall of the maxillary sinus and gets the anterior superior alveolar nerve that innervates the anterior incisor teeth, and it gets the middle superior alveolar nerve to the premolar teeth. And it works quite well. The start time here about 15 minutes before the patient's really completely numb to start the procedure. That's a little bit slow in my book, but it's not too bad. But the big problem with this, in my opinion, was that it was just too doggone expensive. It was about $40 plus or minus per patient to use this. And I think that was just prohibitive and a bad marketing thing. And unfortunately, this product is no longer on the market. Excuse me. I don't know if we'll see it come back. If we do, it better be at a lower price if they ever want to have success with it. But I'm glad to see that people are trying to come up with new ideas. Here's another idea, if you will. This was some research about acupuncture. So teeth with irreversible pulpitis, so hot teeth, hard to get numb teeth, with using a conventional inferior alveolar nerve block alone, they had 20% success. When they combined that with this particular acupuncture site here, the L14 Hegu point here in between the thumb and the hand itself, the success rate with a conventional IA block went up to 60%. And you go, wow, that's pretty significant increase there. That's perhaps a workable idea. But I don't know. I'm thinking about this and going, I don't know if patients are going to be any more enthused about getting a needle stuck somewhere else in their body rather than in their mouth. And, how many needles is it really going to take to accomplish the purpose of getting local anesthesia so you can work on the patient? So, yeah, maybe this could work, but I'm not really thinking it's one of the better ideas. This, I think, is a good idea. Iontopheresis. This is something that's used in medicine. You have 2 electrodes. One electrode is pushing the drug into the tissue. The other electrode is creating an electric current that draws the drug down into the tissue. This is used in medicine already to deliver medications for patients. It's needle-free, so there's no pain involved with this. Very rapid onset and prolonged duration that you can have with this. For dentistry, the problem is, can we get this drawn down deep enough into the tissue? For example, can we draw it deep enough down into the cheek to penetrate down to the level of the inferior alveolar nerve to accomplish anesthesia there? And so far, they haven't come up with a system that works reliably, efficiently, or that you don't have to turn up the electrical power so much that it becomes uncomfortable for the patient. So it's an idea that's in progress. We'll see whether this ever comes about or not. A couple other things. Cryotherapy has been around for a good while. Anesthetic solutions will dissociate better and achieve anesthesia and also provide a longer duration of anesthesia at lower temperatures. And also, if you have the local area numb with cold, then the patient's not going to feel the injection as much. We've proven this already when we use ice sticks or endo ice on the tissue as a topical anesthetic. So this is something, again, that's being experimented with, but not quite at the point of putting it on the market at all. Light reactive anesthetics. I think this one's really pretty cool. You inject your anesthetic, and then you use a violet light to turn the anesthetic on. And when you're done with your procedure, or at least the painful part of the procedure, you turn on a green light and it turns the anesthetic off. The patient is instantly no longer numb. So it's the ultimate on-off switch, which I think would be pretty cool. I like this idea. I don't know quite how close it is to any marketing yet, but they're working on it. So I'm glad to see that people are doing research to try to come up with better ways, more efficient ways, and more comfortable ways for us to give anesthesia. All right, now speaking about on-off switches, for the off switch, I'm sure you've all heard of Oraverse, the anesthetic reversal agent. This is the only off switch that we have. And what this is really being used for, indicated for, is to turn off soft tissue anesthesia. So anesthesia of the lip and tongue and all the functional aspects. And it doesn't really instantly turn it off. It just speeds up the recovery time to about half of what the normal duration of anesthesia for soft tissue would be. So it accelerates the return of the patient to normal function so that they can go back to work and speak and eat and do all the normal things that they like to do. So what this is Phentolamine Mesolate, which has been in medicine for a long time. It's a vasodilator that has been used in heart surgery, organ transplant surgery, things like this, to maintain good blood perfusion through these organs. It's administered by an injection. So we would give this as a turn-off agent. We would inject this into the same site where we gave our local anesthetic injection. What it does is it dilates the blood vessels at the anesthetic site, so it speeds up the removal of the anesthetic from the tissue space into the vascular system. It speeds that up, and basically it's reversing the effect of vasoconstrictors. Now, it's not doing this at such a rapid rate that it potentially could cause toxicity. This is just speeding it up to about double what the normal decline of anesthesia would be. So how we recommend using this is once you've completed any potentially painful part of your procedure, you've prepped the tooth, whatever like that. Now you're getting ready to fill it. Well, filling it's non-painful. So we could go ahead and administer the Oraverse at that point when we're done with the drill. And then by the time we're done doing the filling, adjusting the occlusion, polishing, whatever we need to do there, the patient's probably already starting to lose their numbness. So as they're walking out of the office, the anesthesia is already starting to wear off, which can be very impressive to patients. I think case selection is important. Special needs patients and children. These are patient populations that are more likely to injure themselves with prolonged numbness. Adult patients, business people that need to get back to work and they don't want to have that feeling of numbness persisting. And then you've got those patients who just flat out do not like to feel numb. They don't like that feeling of numbness. So this is not something that you're going to use for every patient, but I think it's something that is very useful. And I think that most dentists, I've talked to a lot of dentists and they say, oh, my patient doesn't need anything like that. They're not bothered by being numb. Well, I want to ask you, have you actually asked your patient about this? Have you had a conversation with them? Because I'm willing to bet if you asked your patients, you would find that you have a decent pool within your practice who would be interested in having the anesthetic reversed if you can do that. So to me, it's a service that we can offer. It's an option that we can offer our patients that sets us apart from a lot of other practices. Most practices that use this, they do charge a fee for it. It's not covered by insurance or anything. When they first introduced this product, it was expensive. It was about $20 a cartridge. Now it's down to about $8 a cartridge, maybe even a little less than that on special, which I think is very reasonable. And most practices are charging $15 to $20 for this service of reversing anesthesia. So to me, it's just one more thing, one more thought that is a consideration to your patient, showing them that you really care about how they feel. And it's just one more thing, again, that sets your practice apart as really, really caring about each individual patient. All right, let's get to a couple of newer thoughts, if you will, about pharmacology. We know that our local anesthetics are probably the safest medication in all the health sciences. However, we also know that adverse reactions can occur. Psychogenic reactions, which very simply are feigning reactions, are not uncommon. Now, you know as well as I do, the patient isn't actually feigning because of the local anesthetic. The patient is feigning because of their anxiety about receiving a shot of local anesthesia. Allergic reactions, toxicity reactions, these are very uncommon, but they can be very serious. These could be potentially fatal reactions here. And then last, we have the idiosyncratic reactions. These are the weird things that patients report. You know, and I get asked a lot of different questions about these things. You know, someone will come up to me at the end of a lecture and they'll say, hey, you know, I had a patient the other day. I gave an IA block on the patient's left side. The jaw got numb. Everything was fine for doing my dental work, but the patient reported the big toe on their right foot got numb. How did that happen? It's like, you know, I have no idea. There is no anatomical connection. There's no pharmacological pathway that I can dream up. Your patients just belt differently, I guess. That's about all I can say. It's just weird. All right, in terms of the adverse reactions, syncope feigning reactions, this is the most common medical emergency in the dental office. And again, it's due to stress and anxiety in the patient there. A couple things that can contribute to feigning, though: low blood sugar, lack of sleep, or dehydration. So I always tell my patients, eat a good meal before you come in. You know, if you don't eat before you come in, and if you're going to remain numb for a while after the procedure, you're going to be really hungry. And I don't want you pushing that envelope and injuring yourself by trying to eat something before the anesthesia is completely worn off. So go ahead and eat a good meal before you come into the office. Try to get a good night's sleep and drink plenty of fluid. Okay, right. I know you're worried that you're going to need to go to the bathroom during the appointment. Hey, you know what? It's a normal human function. It's okay. If you need to go to the bathroom, just raise your hand and I'll let you go to the bathroom. No problem. But these things can really help to minimize the risk of feigning. This last thing here about hormonal fluctuations, this is not a big deal, but every once in a while you might find that you're having difficulty with anesthesia on a patient, and more likely to be a female patient than a male patient, but not exclusively by any means. So it might be worthwhile to ask, particularly the female patients, about menstrual cycle, because hormonal fluctuations can affect the success of our local anesthetics. So it's something to think about, something to put away in the back of your mind. In order to avoid feigning, I give virtually all of my injections with a patient lying down, at least if they can lie down. I've got some patients, it's like, no, 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 you can't lie me down. I get it. All right, fine. But if I can, I lay the patient down, I give the injection. When I take the needle out, I say, hey, Mrs. Jones, you did great. You know, I'm glad to see you're still breathing. That's a real good sign. You know, I just kind of mess around with them a little bit. And, you know, then I start to ask them, you know, do you feel any numbness starting to come on, blah, blah, blah. The point is that I don't give the injection, take the needle out, and then immediately sit the patient up. Because when you're giving an injection, the average patient is nervous. They're gripping the arms of the chair. Their toes are all wadded up in their shoes. They're white knuckled. So as soon as we take that needle out of their cheek, they relax. Blood rushes back out to all the extremities. And if you sit them up right away, their brain is not getting as much blood, not as much oxygen as it was just a moment ago. And the body goes, or the brain goes, I should say, hey, what happened? If the patient faints, they fall down flat on the ground and more blood goes back to the brain. So let's just leave them laying down for a little bit and avoid that whole scenario there. All right, allergic reactions. Allergic reactions are not very common anymore. We used to have the ester anesthetics, and the rate of allergic reaction was maybe as high as 10% of the population had potential allergies to the ester anesthetics. And a big problem with the ester anesthetics was that if they were allergic to one, because of cross reactivity, they were likely to be allergic to multiple, if not all, ester anesthetics, which was very problematic. But none of these esters are in dental cartridges. All of our injectable anesthetics in dentistry are amide anesthetics. So the esters are still out there, they're available, but they're only available in medical multi-dose bottles. Our dental cartridges with the amides, the incidence of allergic reaction to the amide anesthetics is very rare. But I want to stress it can occur. It is real, it can occur, but it's very, very rare. When a patient comes in and tells me that they're allergic to lidocaine, I can't say, oh no, that's very unlikely. I've got to appreciate that it might be true. So the best way to find out if it really is true is to have them patch tested by an allergist. And I'll talk about this a little more detail in just a moment. Patch testing is not the most reliable test, but it's the simplest, easiest test. Okay. A good thing about the amide anesthetics that I noted here is that it is very, very, very unlikely that a patient might be allergic to lidocaine and will be allergic to other amide anesthetics because they are not cross-reactive. All right, so in terms of allergic reactions, you need to ask some careful questions of the patient. You know, did they feel that they had some rash or itchiness or some puffiness, anything like that? You want to get a full history of what happened. You know, most of what I hear as being allergic reactions are not allergy reactions at all. What they are is stress reactions, okay? The patient's nervous. So what I want to hear is something kind of like this cartoon here. We think the tartar controlled toothpaste is rejecting the tartar sauce on the fish. It's like, okay, you know, is it really an allergic reaction or not? So again, allergy to amides do exist, but it's a very, very small likelihood. Now, primary reasons for allergic reactions to dental local anesthetics. So first off, preservative in our anesthetic solutions. It used to be that our anesthetics had a little bit of methylparaben as a preservative in the cartridge. And methylparaben is metabolized by the human body to PABA substances. And a lot of people are allergic to PABA substances. And this was discovered back in the 1950s. PABA used to be in a lot of skin creams, sunscreens, and stuff like this. The methylparabens, PABAs were taken out of these products a long time ago. The FDA took these out of dental cartridges in 1984 because our dental cartridges are single use. And so the FDA wisely said, there's no reason to have a preservative in the cartridge because you're not using this over time once you've opened the cartridge. You use whatever part of it or all of it, and then you throw the cartridge away. We don't need preservative in there. The ester anesthetics were good anesthetics, but again, high allergic incidence in the population and cross-reactivity. These were all replaced by the amide anesthetics in the mid-1990s. When we started learning about, you know, HIV and communicable diseases, infection control, things like this, you know, we started wearing gloves. I remember going to dental school. We were proud to be wet finger dentists. We only wore gloves in in oral surgery. Well, nowadays we wear gloves for everything. I won't touch a patient without having gloves on. And a lot of people, as we started wearing gloves more, they started developing latex allergies. And the cartridge little stopper and the diaphragm in the cartridges were made out of latex. And what we found is that molecules of latex could be found circulating in the anesthetic solution within the cartridge. So latex allergy was a problem. But since the early 2000s, the manufacturer switched to silicone, which has no allergenicity whatsoever. So latex is removed from the equation. So there is one thing and one thing only that is likely to cause, actually got to change it. There is one thing that's more likely to cause allergy than anything else, and that is if you're using an anesthetic with a vasoconstrictor, there is a little bit of antioxidant in there to protect and prolong the shelf life of the vasoconstrictor. That's either a sodium or a potassium metabisulfite, all right? So sodium metabisulfite. So your patients that report that they're allergic to sulfur, they're allergic to sulfa, sulfonamides, Bactrim, Septra, these are not the same thing as sulfites. Sulfite sensitivity, more common in corticosteroid asthmatic patients, but what you want to do to learn whether your patient has any issue with sulfites is to ask some food questions. If they can eat dried fruits, drink beer and wine, eat salami, these preserved pepperoni meats, things like this, these all have a lot of sulfites in them. And also a lot of food markets spray sulfites on their produce, on their fruits, on their vegetables, on their meat to preserve the appearance of freshness longer. So if patients are allergic to sulfites, they know because of their food sensitivity. And so just ask them about the foods. If they report they're allergic to sulfites, then you do not want to use any local anesthetic that contains any kind of vasoconstrictor. Doesn't matter whether it's epinephrine, levonorepinephrine, neocobephrine, whatever. You don't want to use a vasoconstrictor. You want to only use a plain anesthetic if they have a sulfite allergy. All right, I mentioned about patch testing. So what patch testing is injecting a little bit under the skin here. What's important if you're going to have your patient patch tested is don't just send them to the allergist and ask the allergist to test for lidocaine, bupivacaine, blah, blah, blah. You want to send a dental cartridge of each of your anesthetics, either send that to the allergist or have the patient take it to the allergist. You want to test what's in your dental cartridges, because if you don't send what you use, what the allergist will do is they will use a multi-dose bottle of anesthetic, which again, multi-dose contains other preservatives like methyl, paraben, other preservatives. It's not as clean as our dental cartridge. So when a patient comes into me and says, oh, my doctor told me I'm allergic to lidocaine, I go, okay, but I don't necessarily believe that they're truly allergic to lidocaine. I suspect there's a very high likelihood that what they're allergic to is one of the other ingredients in the multi-dose anesthetic vial that the physicians use, but we don't use that. Now, like I said, patch testing is not completely reliable. The most reliable test is the challenge test. And if you understand what that is, very simply, the patient says they're allergic to lidocaine. I say, okay, great, fine. I'm going to inject lidocaine. I'm going to see what happens. Well, if the patient drops over with an anaphylactic reaction, I'm in trouble. So no, I don't want to do a challenge test in my dental office. And this is why I'm sending the patient to the allergist to find out if there truly is an allergy to one of the amide anesthetics. So I want to test for each of the amides that I use in my office, and I want to have the patient tested for one ester as well, so that I have a full spectrum of things that I potentially can use for the patient. So that's a safe way to go when a patient reports an allergy. And you're sure that it was an allergy, it wasn't just a stress reaction. Okay, in terms of toxic reactions, toxicity reactions, simple way is we want to limit the total dose of anesthetic that we're delivering. And if we use a vasoconstrictor in the anesthetic, it does slow down the uptake of the anesthetic into the bloodstream, which means that the dosage within the bloodstream will always be at a lower level. And it's important to understand that if we're using a vasoconstrictor, that means that at any given point in time after giving the injection, the titer of local anesthetic in the patient's bloodstream will always be lower with a vasoconstrictor containing anesthetic than it will with a plain anesthetic with no vasoconstrictor, because the plain anesthetic will be taken up into the bloodstream faster and at a higher total dose rate. In terms of local anesthetic dosage, you can see here for lidocaine with 1 to 100,000 epinephrine, we can use 11 cartridges. That is a lot of anesthetic. Now, actually, the truth is, as far as lidocaine is concerned, we could use 14 cartridges. The 11 number is because of the presence of epinephrine. It's the epinephrine that knocks our total safe dosage down to 11 cartridges. Okay, but still 11 cartridges, you know, for most general dentistry, I'm using 1, 2, 3 cartridges of anesthetic. Rarely am I using much more than that, and certainly nowhere around 8, 9, 10, 11 cartridges of anesthetic. So what this means is that with lidocaine, we have a very large safety margin in terms of dosage. With mepivacaine, which is either plain or with 1 to 20,000 levonorepinephrine, again, you can use 20 cartridges. Now, if you use mepivacaine plain, so this would be, for example, commercial name plain carbocaine, now you're down to only 7 cartridges as maximum dosage. With articaine, with a vasoconstrictor, it's 7 cartridges as well. With prilocaine, sit-nest, with or without vasoconstrictor, it's 8 cartridges as your maximum dosage. Again, for most situations, I'm using 2, 3, maybe 4 cartridges. I'm nowhere near the maximum dosage on any of these anesthetics. But let's say that I'm extracting erupted wisdom teeth in all 4 quadrants. It would not be uncommon for me to use 2 or more cartridges per corner of the mouth, and that would readily put me over a maximum of 7 or 8 cartridges. So you need to think about what your procedure is going to be and how much anesthetic you're going to use in each given site. What's the total sum of the amount of anesthetic you're going to use? There's no contraindication for mixing our anesthetics in any combination that we'd like to. The only thing is we have to remember that our anesthetic solutions are additive in dosage, and therefore, whichever anesthetic is of the highest concentration, we don't want to exceed the maximum safe dosage of that anesthetic agent. Okay, so that means if we're going to combine lidocaine with sit-nest, it's not halfway between 13 and 8 is the maximum dosage. Nope, it's the sit-nest, the prilocaine, that sets the maximum dosage level at 8 cartridges. If we're mixing lidocaine with articaine, with septicaine, then septicaine sets the limit at 7 cartridges. All right, so you need to be aware of that, pay attention to that. The other thing is with kids, children have a higher metabolic rate, which means they're going to take the anesthetic up out of the tissue space into the bloodstream faster than will occur in an adult, okay? And this is why the recommendation for children is to make sure that the calculation is based upon the child's weight. And so here's a chart, and I'm always hesitant about charts, but for example, a 10-year-old child, it says you can use a little over 5 cartridges of 2% lidocaine with 1 to 100,000 epinephrine. I think that's still a lot of anesthetic and more than we would normally use. But let's say we're going, okay, 10-year-old, I can use 5 cartridges. Well, what happens if the child is small for their age? Well, now if you use 5 cartridges, you've overdosed that child. And heaven forbid, this is where we see most of the toxicity instances occurring, where somebody gets a little inattentive or cavalier, however you want to look at it, and they overdose a person on local anesthesia. It happens much more likely with a child, and unfortunately with a child there's less buffering capacity, and it's more likely to be a fatal incident. And this is what we hear about in the news from time to time. When you hear about a death from local anesthesia, it's almost always a child, and it's almost always because somebody wasn't paying attention to the weight. I like this rule of 25. This is a real quick, simple way to calculate how many cartridges to safely use. So what it says is that for every 25 pounds of weight, you can safely use 1 cartridge of anesthetic. It's a very conservative guide, if you will, but it certainly is a very safe guide and works for most situations. So I think it's a very handy thing to keep in mind. All right. So vasoconstrictors do help us to maintain the safety of our local anesthetics. But the question always comes up, hey, is it safe to use epinephrine? Is it safe to use vasoconstrictor on my hypertensive patients? My question is always, is the patient stabilized as a hypertensive? In other words, they've been diagnosed as hypertensive. What is their blood pressure controlled at? Is it below, or is it within a close proximity of a high level? Most important, is it stabilized at a consistent level? Maybe it's high, but is it stabilized at a high level? If they have stabilized hypertension, you can pretty much treat them just like a normal average patient. There's been quite a number of studies that have shown very clearly that the use of 1 or 2 cartridges of an anesthetic with a vasoconstrictor containing anesthetic has very little impact on the cardiovascular system if the patient has stabilized hypertension or virtually any other cardiovascular disease. But the key is the patient is stabilized, okay? And think about the benefits of maintaining adequate anesthesia. If I use a plain anesthetic, which tends to wear off fairly quickly, and if I don't anticipate that wearing off and the patient starts to feel pain in the middle of the procedure, they are going to produce a lot more endogenous epinephrine than anything that I'm injecting in a dental cartridge with vasoconstrictor. So what I say for your patients with hypertension is, I always ask them, about their medical history. Are they taking medication for their hypertension? Did they take their hypertensive medication today? I'm going to check their blood pressure before I give an injection, before I start doing anything invasive. Are they controlled? That's the most important thing to determine. If they're controlled, go ahead and use your vasoconstrictor. If they're not controlled, don't use vasoconstrictor. And in fact, if they're not controlled, it's questionable whether you want to treat them at all. Because if they're not controlled, they are more likely to have an adverse reaction because of stress during the dental appointment than from anything that you're injecting. All right, let's take a little closer look at epinephrine, because this is kind of a touchy subject to me, I think, anyway. So how much epinephrine is really in one of our dental cartridges? So here you see 1 to 100,000 epinephrine. It's 18 thousandths of a milligram per cartridge. And if it's 1 to 200,000 epinephrine, it's only 0.009 milligrams per cartridge. That's not very much. So maximum dosage of epinephrine that's recommended in terms of dental treatment. For a healthy patient, we can give, this is for a healthy patient with stabilized condition. We can give up to 0.2 milligrams of epinephrine. So that would equal 11 cartridges of 2% lidocaine with 1 to 100,000 epinephrine. So that's where that number comes from. Now, for the cardiac patient, the hypertensive patient who's stabilized, we can only use 0.04 of a milligram. So that would be a little over 2 cartridges of 1 to 100,000, 2% lidocaine. So that's where these calculations and these studies come from, that, yeah, you can safely use 2 cartridges with a vasoconstrictor. Now, take this a little step further. In terms of production of epinephrine endogenously from the adrenal glands, if a patient is stressed, if they're excited, if they're in fear, their fight or flight response, their sympathetic response, is going to dump a lot of epinephrine into their bloodstream, the equivalent of potentially 16 2/3 cartridges per minute. 16 2/3 cartridges per minute. That's way more than we're injecting in our dental treatment. And think about a patient who's having an anaphylactic reaction. What are we instructed to do? We want to give an intramuscular injection of 1 to 1,000 epinephrine, okay, into their thigh or into their biceps. That's the equivalent of 30 to 50 cartridges of a vasoconstrictor containing anesthetic, just depending on, the concentration of vasoconstrictor in the cartridge. So, what we're talking about in dentistry is very small amounts of vasoconstrictor, and the purpose is to keep the anesthetic in the tissue space close to the nerve. A piece of advice for you is do not ask a physician, may I use epinephrine on my patient? Because the physician will give you a medical answer. They won't give you a dental answer because they're not dentists. They don't know the dental answer. The medical answer, physicians use epinephrine in large quantities, and they inject it directly into the bloodstream or into the muscles that are highly vascular. We are injecting it into the tissue space in very small amounts to keep the anesthetic out of the bloodstream so that we have longer duration of anesthesia. So understand how we use it, understand how physicians use it, and understand it's not apples and apples. All right, safety guidelines. We see more and more medically complex patients, which is the miracle of modern medicine, that patients with conditions that used to keep them homebound can now be highly functioning in society. It's wonderful. But, this recommendation about reducing the amount of vasoconstrictor to no more than 2 cartridges. If I need more volume of anesthetic after I've used 2 cartridges, switch to a plain anesthetic with no vasoconstrictor. This will not reduce the duration of your anesthesia. Your prior 2 cartridges will give you that duration. This won't dilute it down, but it will decrease any likelihood of an adverse reaction to an additional volume of vasoconstrictor. All right. In terms of metabolism of our local anesthetics, continue with a little pharmacology here. The amide local anesthetic agents are all biotransformed, fancy name for metabolized, in the liver by the P450 cytochrome enzymes. Now, I think what's interesting, well, a couple things first. The P450 enzyme system, it also is the primary enzyme system for metabolizing a lot of medications that patients take, whether it's prescription or over the counter. So there can be competition for the P450 system there. An interesting thing is that Articaine, most common commercial name again is Septicaine. Articaine is very different from our other amide anesthetic agents. So here's lidocaine. This was our first amide agent that was synthesized in 1948. It's got a benzene ring with an amide chain on it. Articaine is the only amide anesthetic that does not have a benzene ring. It's a thiophene ring, and it has, yes, it has an amide chain on it, but it also has an ester chain on it. So Articaine is actually a hybrid anesthetic that's halfway in between an ester and an amide. It's classified as an amide because it has the same characteristic, very low risk of allergenicity that all of the amide agents have. But because of the ester chain on Articaine, as soon as that starts to enter the bloodstream, the blood starts to metabolize it. And in fact, most of the Articaine, 90 to 95% of that anesthetic solution of Articaine will be completely broken down in the bloodstream. So there's only a very small amount that's going to reach the liver to still be broken down by the liver. So what this means is that if you have a patient with impaired liver function, they have a history of alcoholism with cirrhosis or hepatitis, anything like that, Articaine is probably your smarter, safer anesthetic to give to those patients because it will put less burden on the liver and it will be cleared out of their bloodstream faster with less risk of any toxicity than your conventional amide anesthetics. All right, another thing that I'm sure you've heard about over the years, but I don't know, most of us probably didn't know too much about it, is this thing about methemoglobin. all of us do have a little bit of methemoglobin circulating in our blood. As you know, hemoglobin is a very good oxygen transporter, and we want a lot of that in our blood. Methemoglobin is not a good oxygen transporter. And what we find is that excessive doses, large doses of local anesthetic can increase the amount of methemoglobin that's normally circulating in our system. And this can also be increased by certain drugs that patients might be taking. So acetaminophen, nitroglycerin, or the sulfonamides are big ones that can increase the risk of toxicity due to methemoglobinemia. So particular caution is recommended with Prilocaine, with Citinest is a commercial name. This is written in the package insert for Prilocaine. It's very small print, and most people haven't read the package insert, but it says to be careful about Prilocaine because of methemoglobinemia, and especially with patients who already have some oxygen transport issues. So chronic obstructive pulmonary disease, emphysema, patients who are anemic, they don't have good oxygen transport. For pregnant patients, it's not the mother that we're concerned about, it's transport of oxygen across the placenta to the baby that we're concerned about. So Prilocaine has an issue potentially with these type of situations. So let's talk about pregnancy. Excuse me. All right, drink of water there. Let's talk about use of these anesthetics during pregnancy and breastfeeding. So there are no contraindications to using local anesthetics during pregnancy. I want to stress that. Now, best practices do recommend that during the first trimester, if you don't need to do anything that requires local anesthesia, then don't do it. Let's make it as safe as possible. If you need to use a local anesthetic, particularly with vasoconstrictor, the best time to do it is during the second trimester or the first half of the third trimester. And then again, let's try to avoid using any local anesthetic during the last half of the third trimester. So you guys know this already. You've heard this many times, but let's take this a little bit further here. The FDA has classified our local anesthetics for use in pregnancy, all right? So lidocaine and prilocaine are classified as FDA category B, which is, animal studies indicate that there's some problems, but these have never been duplicated in humans. Category C is basically saying, well, there aren't any good studies in animals and there's no studies in humans, so we don't really know. Okay. And if you think about it, what woman in her right mind is going to volunteer to say, oh, yeah, test some drugs on me to see whether it hurts me or hurts my baby? It's not going to happen, and therefore we don't have the research on it. Well, the FDA has tried to address this issue, realizing that these categories that they had weren't terribly meaningful to us. So they've done away with these categories. And what they're trying to do, but haven't completely succeeded in doing yet, is to give us a more descriptive use protocol for our local anesthetics. So I thought this is interesting here. Again, human data about these drugs is very limited or absent. Pregnant women are usually excluded from any clinical drugs because we're concerned about injury to the baby. So, we don't have the research that's needed to really know about these things. So we'll use a little bit of our historical anecdotal information, if you will, and a little bit of the science that is available to us. So looking at our categories here, the risk of methemoglobinemia, we know it is increased with topical anesthetics and also with injectable prilocaine. This is an FDA known fact, which leads me to say prilocaine should not be in category B according to the FDA information. That should be crossed out. Lidocaine is the safest. Now, lidocaine is only available in dental cartridges with epinephrine. Well, epinephrine is okay in our dental application. Again, don't ask the obstetrician, can I use epinephrine? Because they're thinking medically. They don't understand that we're using it dentally in very small amounts into the tissue, not into the bloodstream. Okay, so 2% lidocaine with 1 to 100,000 epinephrine is the safest anesthetic to use during pregnancy, according to the FDA. And that makes perfect sense. And again, we only use as much as truly necessary, right? Well, that's what we do in all of our patients every day, day in and day out. It's not just for the pregnant patients. We only use what we really need to use. Okay, let's take this a step further here based on the science. Now, we know that articaine, because of the ester moiety on articaine, it has the shortest elimination half-life in the bloodstream. So once it gets into the blood, it's going to disappear faster than any other anesthetic. All right? So that means that fetal exposure from the bloodstream to the anesthetic is going to be smaller and at a much lower level with articaine than with any other of the anesthetics, because it's cleared out of the mother's bloodstream faster. And if the mother is nursing, articaine is cleared out of the bloodstream faster than any of the other anesthetics. You can see 4 hours versus 9 hours for the other anesthetics. So the mother can nurse with no concerns about transmission of the anesthetic through the breast milk at a much sooner timetable. And articaine is also available with a lower concentration of epinephrine, the 1 to 200,000 formulation, which is my favorite. So I want to say articaine is logically the safest anesthetic to use for your pregnant and nursing patients. And I hope that makes sense from a scientific standpoint, because that's what the chemistry says. It is logically the safest anesthetic to use. And again, only use as much as you truly need to use. It's a 4% solution. You probably don't need to use as large of a volume as you did with your 2% lidocaine and so forth. Okay, let's move on here. Got more stuff I want to share with you. Reasons for anesthetic failure. And yeah, I mean, we all have them, including me. I'm no expert who never has a failure, believe me. The first two, I think, are the main reasons why we have anesthetic failures, but inflammation and infection is a very big problem that we all face, okay? So hot teeth, hot gums, infected teeth with irreversible pulpitis, severe periodontal infections, hypoplastic teeth, and teeth with occlusal trauma, things like this tend to be very hypersensitive. They can be very difficult to get anesthetized. So we were taught way back in school that we would give a block injection as far away from the site of local inflammation or infection so that we would get normal dissociation of the anesthetic solution to achieve anesthesia by injecting in this more remote site rather than right next to the tooth where the infection is. Now, in truth, if we did inject close to the tooth, plain anesthetics have a better dissociation at the site of infection. All right. But the problem is that plain anesthetics are also vasodilators, which means they're going to open up the blood vessels. And by the way, in a site of infection or inflammation, it's usually erythematous, right? Which means that there's more vascular supply. So plain anesthetics are going to wash out very rapidly. It's going to be an extremely short duration of action. Now, articaine, only available with vasoconstrictor, also tends to give better dissociation in a site where we have infection or inflammation. But again, it's still not going to be your cure-all answer for everything by any means. So we need to think a little more carefully about things. Here's a paper, again, this was published in the triple O or quadruple O, whatever it's called nowadays. This is dealing with teeth with irreversible pulpitis. And what they did is, using different techniques on the mandible, they were able to achieve successful anesthesia with a Gaugates injection 52% of the time, conventional IA only 36% of the time. And you're going, oh, wow, that's not very good. To me, that's interesting, but the most important part of the paper was this statement right here. No technique was fully acceptable by itself. What that tells me is what I already knew, actually, and that is that when I'm dealing with a hot tooth, I'm going to give my block but it's probably not going to be completely successful. I'm probably going to need to use some secondary techniques in order to truly get profound anesthesia. So thinking about things that can help us to get good anesthesia. You know, we've, for a number of years, we've been told, hey, give the patient ibuprofen before we do oral surgery, before we pull out a tooth. They'll have less postoperative pain. Well, here's from an endodontic study, this was published in JADA, that giving patients ibuprofen an hour before endodontic treatment, it made the patient more comfortable, less likely to feel any discomfort during the endodontic procedure than without the ibuprofen. So I say anytime that you're dealing with a hot tooth, that you're dealing with one of these situations here, have the patient take ibuprofen before they come into the office if you can. It will make your anesthetic work better. Here's another paper, again from JADA, dealing with teeth with irreversible pulpitis. They only gave one cartridge of anesthetic, okay? And this was again on the mandible inferior alveolar conventional technique. So Articaine, Prilocaine, you can see the numbers here. Articaine, 73% success, Lidocaine only 12%. That's terrible. But again, I think this is probably a more important part of the paper here. They said that increasing the volume of anesthetic from one cartridge to two substantially improved the success rate for all anesthetics. And I want to stress that 2 cartridges is better than 1. Let me build on that a little bit here. In terms of the right volume of anesthetic, for infiltration injections, usually about 1/2 to 3/4 of a cartridge is pretty good, okay? We're going to use less for kids because they're smaller. For an inferior alveolar nerve block, 1/2 a cartridge tends not to work well enough. The ideal volume is 3/4 to a full cartridge of anesthetic for adults. Now, I want you to think about when you went to school, you were taught the basic conventional bisection technique for the IA block. So what'd you do? You went in and gently touched bone at your full depth. You backed off slightly, aspirated, dropped how much anesthetic? 1/2 a cartridge, 2/3 a cartridge, 3/4 of a cartridge. And then you backed out halfway, you stopped, aspirated again, and dropped the rest of your anesthetic to get the lingual nerve. So what I want you to understand is what you just did with that one cartridge is that you got a very minimal volume of anesthetic on the 2 nerves. So your odds of having complete profound anesthesia are borderline. And there have been a number of studies that have shown very clearly that by adding a second cartridge, you can increase the profundity of your anesthesia, the success of your anesthesia, and decrease the onset time. So what you want to do is give that first injection, give it a couple minutes so the local tissue space where you're giving your IA block is anesthetized. Now come back and give a second cartridge. Don't expect one cartridge to be the end all for your IA. And if you don't get profound anesthesia with one cartridge, you are a bad dentist. You are a bad dental hygienist. That is not true. I think that's very foolish to believe that. Give the additional cartridge, make your life simple, and improve your patient's comfort level. It's easy and it's very safe. We're not talking about large doses of anesthesia here. All right, let's come back to the hot tooth situation and alternative things that we can do if the block's not going to be sufficient. So we can give a PDL injection or an intraosseous injection. PDLs are quick and easy to give, only short duration. I'm not a big fan of PDLs because I find too many patients report that they're uncomfortable in that area for a couple, 3 days afterwards, because we injured the PDL. Every time the patient bites down, they're tweaking that injury. It doesn't feel good. Intraosseous injections were used pretty commonly by endodontists, but they're kind of cumbersome. I'm not a big fan of those either. So what we're seeing in the endodontic literature is that the endodontists are saying, give your block, and then if you need secondary injections, give a buccal and or a lingual infiltration with articaine. You can use prilocaine, but use a 4% anesthetic solution. Now, I personally say, get rid of the or, give both a buccal and a lingual infiltration. And let me explain why here real quickly. So, you know, when I went to school, we didn't have Articaine. So lidocaine did not work very well in the posterior mandible. But this was a study that was done by Robertson and his colleagues at The Ohio State. What they did is a single buccal infiltration over the first molar of the mandible. They gave that full cartridge over the buccal of the first molar, and then they pulp tested from the second molar to the first premolar. And what they found with lidocaine is that 45% of the time they had pulpal anesthesia. With the first premolar, that was with the second molar. With the first premolar, 67% of the time they had pulpal anesthesia. Doing that same thing with Articaine, 75% success pulpal anesthesia with a second molar, up to 92% success for the first premolar with that buccal infiltration. And they also found that the onset was much faster with Articaine, less than 5 minutes, where lidocaine was 6 to 11 minutes for onset. Now, the other thing we know about Articaine is that if you give a buccal infiltration, you'll get buccal tissue, you most likely get pulpal tissue, and sometimes you might get lingual tissue, which would mean I wouldn't have to give an additional lingual injection. And most of my patients are happy that I don't give them a whole ton of injections. The fewer times I stick them with a needle, the more comfortable they are. All right, I want you to think about anatomy here. For the posterior molar area, we have a thin lingual plate here, right? We're told be careful in extracting molars on the mandible because we might fracture that lingual plate. Well, if I'm doing an infiltration, wouldn't a lingual infiltration make more sense? It's got less bone to traverse through to get to the apex than the buccal side does. Now, I know you're thinking, oh my gosh, but there's big blood vessels in the floor of the mouth and things like this. Hey, you know, the blood vessels are way over underneath the center of the tongue. The only thing down below here that's next to the alveolar process, next to the bone, is the submandibular gland. So there's nothing dangerous about an infiltration into the floor of the mouth as long as you're close to the alveolar process. Now, if I give this lingual infiltration, I'll get lingual tissue, probably pulpal tissue. Will I get buccal tissue? Well, maybe, maybe not. And so that, you know, I don't like this maybe, maybe not thing. And that's why I say give both a buccal and a lingual infiltration. A half or a full cartridge on the buccal, a half or a full cartridge on the lingual side. And, you know, you're giving this only at the depth of penetration to the apex of the tooth, and you're giving this slightly distal to the last tooth you need to work on because the innervation is coming from the posterior, right, in the inferior alveolar nerve, coming from the back forward. Okay, looking at Articaine, and again, you know, I'm not a salesperson for this stuff, but I think it's a good anesthetic. In looking at clinical trials, very good research work, looking at 13 papers combined together in a meta-analysis, evidence strongly supported Articaine's superiority over lidocaine for infiltration injections. For block injections, the evidence was that Articaine was a little better, but it wasn't really that much better, okay? And then here's from the endodontic literature. Articaine 4 times more effective with greater duration than lidocaine as an infiltration injection when used for teeth diagnosed with irreversible pulpitis. So again, infiltrating with Articaine in combination with their block injection. So let's give the block, the IA block or the Gao-Gates block. Let's give it with lidocaine and then use Articaine for an infiltration closer to the tooth to get more profound anesthesia with these hot teeth. Can you use Articaine in children? Well, Articaine in children gives a more profound anesthesia that's equivalent to an IA block with lidocaine. So that's an infiltration. And is it safe in children? Yes, it is, because the elimination half-life is very, very brief in children because of their higher metabolic rate, okay? So, you know, Articaine is in many ways, you have to consider it safer. The risk of toxicity to a child is lower as long as we're not using excessive amounts, excessive volumes. And you can see here that you know, the amount cleared out of the body in 6 half-lives, which is the standard method of measuring, is about 2 hours for articaine. That's for both adults and children. So that's excellent. All right. So why are these hot teas so hard to get numb? Well, yeah, pH, you know, having proper dissociation of the anesthetic is part of the problem. But it's also, you know, we've learned that inflammation causes an increase in anesthetic resistant sodium channels. In other words, anesthetic resistant receptors. So our anesthetic may not be as effective as it normally would be. Also, the inflammation or infection causes an increase in the number of pain receptors, and it increases the size of their receptive field. So a given area becomes more sensitive. And all of that feedback going up to the brain, feeding pain messaging to the brain figuratively throws up its hands and goes, I don't know what's going on out there in the jaw. All I know is it hurts. And we've heard this from patients. They come in with a toothache and you say, okay, can you point to which tooth it is? And they go, doc, I don't know. I don't know if it's an upper tooth or a lower tooth. All I can tell you is that I hurt. You got to help me. Okay. And then finally, when patients are in pain, it reduces their pain threshold. And we witness this with our patients like this. You know, they come in, you ask them to open their mouth, and they go, it hurts. And you reach in there with your mirror to retract the cheek a little bit, and they go, oh, you know. And I mean, you haven't even touched the tooth, and they're already squirming all over the chair. So, yeah, it reduces the pain threshold. So, short story, hot teeth are tough to treat. Yeah, well, so it means we have to be more intelligent. We need to think ahead. What is most likely to work for the given situation? What combination of things can I use to more successfully achieve my anesthesia? All right, let's back off the hot teeth for a moment here. Can infiltration injection with articaine work for a healthy tooth that's not infected? In other words, can I work on a single mandibular tooth without having to give a mandibular block? And the answer is an absolute yes. Just do exactly what I said there in terms of an infiltration. Half to a full cartridge of articaine on the buccal side, same thing on the lingual side. Inject it distal to the single tooth you want to work on. And in most situations, with most patients, you can go ahead and work on that tooth. You can do the filling, you can do the crown prep, and it will work. Your duration is going to be a little shorter, but most of our dental appointments for a filling or for a crown prep tend to be about 45 to 50 minutes for the entire appointment, or at least for any kind of drilling that we do. And drilling, that's the painful part. So yes, infiltrations can work on the mandible. All right, another thing about anatomy here is that the question comes up, could there be innervation of mandibular teeth coming up from the neck? And there's two nerves, the great auricular nerve coming to the angle of the jaw and the transverse cervical coming across the neck. Can these send branches up into the jaw, up into the mandible? Well, we haven't had very good evidence for that until this paper in the anatomical literature. This was a beautifully done cadaver dissection, 250 cadavers, and they found that branches of those two nerves did reach the mandible in 60% of these cadavers. However, the connection of these nerves to any dental structure, to a dental nerve or to the tooth, was very low. It was about 15% of these 250 cadavers. Okay, so their conclusion was the likelihood of innervation from these cervical nerves reaching up to mandibular teeth is small, but it can occur. So if this does happen, what's your solution to this problem? Well, it's the buccal and or lingual infiltration again. And my favorite anesthetic for infiltrations is articaine, okay? So same thing for this situation. All right, I think this is the last anatomy thing, and then we'll get to the final section and end up here. So troubleshooting, if you have repeated failure to get adequate anesthesia, a panoramic x-ray can give you some good information. This x-ray here, I want you to notice we see one, two, actually see three potential IA canals. And this is an old study here. In looking at 5,000 x-rays, only 4 patients showed evidence in the bone of bifid IA nerves. And you go, okay, not a big problem. I don't need to worry about it. But what we're learning with cone beam technology, 3-dimensional technology, is that the incidence of this branching can be much higher, maybe 15, 16%, and maybe even as high as 30%. So you go, okay, that could be a big problem here. What's a good solution for that? Well, I say use your highest technique for anesthetizing the mandible. Okay, and that's the Gao-Gates technique. It's closest to the foramen ovale, closest to the source. If I knock the nerve out at the source, I don't care what branching occurs lower down. It doesn't matter. I've already got the nerve and its branches anesthetized. So the Gao-Gates is a solution to these problems. Okay, and it's my favorite technique anyway. Last thing, just about, inflammation, infection. Sorry, I just thought of something else here. Anyway, again, when I'm talking about dissociation, we're talking about our active form of the anesthetic, which is what we inject. It needs to dissociate to the unionized form to get into the nerve to achieve anesthesia. Well, the other thing is that if we inject too rapidly or if we inject too large a volume of anesthetic, it will overpower the tissue buffering capability. So this is one of the other reasons why we want to inject slowly to allow the tissue to buffer our anesthetic. Now, there is a way around that, and that is to buffer our anesthetics before we inject it. So buffering puts it in the unionized form when we inject the anesthetic. And what this does is it makes the injection more comfortable because the solution is less acidic. We get very fast onset, potentially more successful, more profound anesthesia. Now, what buffering does, and again, what we're injecting is closer to our neutral normal tissue pH of 7.4. When we inject lidocaine with the 100,000 epinephrine, for example, it's like injecting lemon juice. pH is about 3.5. And we're hoping that the person's body will buffer that to the more physiologic pH that will allow the anesthetic to dissociate. Well, at this normal pH of the anesthetic, only about 1 in 25,000 molecules is in the unionized form, which can penetrate into the nerve. When we buffer, we change that by a huge factor to where now 1 in 4 molecules are in the unionized form versus 1 in 25,000 in the unionized form. So obviously we're going to have a much more rapid onset, much more successful anesthesia. Now, in reading literature about buffering of anesthetics, you'll see a lot of controversy. What we've learned, and this is especially for dentistry, is that if you over buffer the anesthetic, it will precipitate out and not work. If you under buffer the anesthetic, it will not improve anything whatsoever. And what you're buffering with is usually, a commercial grade sodium bicarbonate. And what we find is that commercial grade sodium bicarbonates are at too high a pH to be ideal for neutralizing our local anesthetics for dentistry. So we want to be careful. If you're empirically mixing sodium bicarbonate with your anesthetic now, it may work, but odds are it may not work, or it may not work as effectively as you'd like it to. So the first company that got into buffering business was the Onset company. And they didn't invent anything new as far as anesthetics or whatever. What they developed was a system of producing sodium bicarbonate at a very particular, very ideal pH for dentistry. So what you do is you put your cartridge of sodium bicarbonate into their pen. This is their old pen, by the way, but I like the picture. You put the sodium bicarbonate cartridge in there. There's a dual needle exchanger. You put in your cartridge of local anesthetic. You push the button at the opposite end of the pen here. It takes out a volume of anesthetic from your dental cartridge and pumps in an equal volume of your sodium bicarbonate. So your cartridge is now ideally buffered. You take that out of the pen, you immediately load it into your injection syringe and give it to the patient. Okay. There's another system on the market, the Nutra Medical system here. This is a little larger box, if you will, for mixing the anesthetics here. I like their syringe here. It's a 6 cc syringe. It has both a little audible click and a feel for the syringe, although the syringe does have a little more resistance than our conventional syringe. Both these systems, the sodium bicarbonate remains stable for about 7 days. So, we can get a lot of injections out of that. The one thing about the Anutra system is that it's not using dental cartridges. It's using your medical vials of local anesthetic. So I'm a little concerned, about having a greater incidence of allergic reaction, although I haven't had any problem with that and I haven't heard of any problems with that. The other thing is that it's using commercial grade sodium bicarbonate. So the buffering may not be quite as reliable, but I will be honest and say, hey, the Anutra system works. It's better than non-buffered anesthesia. So, in terms of buffering, it is a more comfortable injection. It's more predictable, more profound anesthesia. But the big thing is it really has rapid onset. And this is true not just for normal teeth, but it's also true for hot teeth, the infected teeth as well. So that's a great feature. So an important thing about buffering is that you don't mix up buffer at the beginning of the day and then use it over the course of the day, because the sodium bicarbonate is very unstable. So you want to buffer just before you inject your anesthetic solution. Your sodium bicarbonate cartridges are expensive, but they're good for 7 days. Cost per day, $12 to $13. Well, it's actually less than that per injection if you're giving a lot of injections. And to me, I think about this expense and go, you know what? If I can get faster onset, my patients are more comfortable, and I have more profound anesthesia, to me, that's a small cost for this greater success. All right, last thing I want to talk about, I'm running out of time, I apologize, but just a little bit more about 4% anesthetics, because I've talked a lot about articaine, and I want to point out there are some things we want to be careful about. So the whole issue about potential nerve injury, nerve paresthesia, came out of this paper in 1995 by Hawes and Lennon, out of a study they did from data collected in the province of Ontario, Canada. And what they stated was that the 4% solutions, both Septicaine and Prilocaine, were more likely to cause paresthesia compared to the other anesthetics. And this was statistically significant when compared to how much of it was being used. So what they found is that over 21 years, there were recorded 143 paresthesias. So the incidence was extremely low. We're talking about 1 or 2 per million injections. So is this a big problem? No, it's not. But do I want to injure my patients? No, I do not. So I want to do everything I can to minimize the risk of injury. But this was, I think, the most important statement in this paper. Although it can occur, the risk of paresthesia from these injections itself, from these solutions, is extremely low. Now, Gordon Christensen and his research group, they did a study here. They had 2 paresthesias out of 13,000 injections. Both of these were with a conventional infraalveolar nerve block. Remember that the Hawes and Lennon study, all of their paresthesias were recorded in the mandible. In a second publication, Hawes and Lennon, continuing on in Canada, they recorded 182 paresthesias. 180 were associated with the infraalveolar conventional technique. One was with a mental block and one was with a maxillary infiltration. Okay, I want you to be thinking about these things. In the US, it's a voluntary reporting system, so not completely accurate, but 95%, almost 95% of the paresthesias reported occurred with a conventional infraalveolar nerve block and a 4% anesthetic solution. So what's the most likely cause of injury? Is it a single cause? Is it because of the higher concentration of the anesthetic solution? Well, it might be a factor, but I don't think it's the exclusive cause by any means at all. So to reduce the risk of nerve injury, which is what I want to try to do, when I'm using the 4% solutions, with this data from these injury reports, knowing that 75 to 95% of all nerve injuries occur from injections of 4% solution with a conventional IA technique, does it not make sense that that may be a technique I want to avoid if I'm using a 4% solution? And that's exactly what this JADA publication said back in 2011. The prudent clinician may consider avoiding these 4% solutions for an IA block if you have a viable alternative. What's an alternative? Gaugate's block, infiltrations, etc., etc. Okay? So, there's no guaranteed method to prevent nerve injuries due to injections. There have been paresthesias reported for all known anesthetic agents and for all known anesthetic injection techniques. So we're never completely, safe in terms of giving an injection. But the risk of injury is very small, and it doesn't mean that you did anything wrong. Okay? But if I can avoid the higher risk of a 4% with a conventional IA technique, would I not want to do that? Would that not be the wise decision? And use an alternative technique? Because it's been shown in studies that these higher techniques are much safer, have a much lower risk of paresthesia with any anesthetic agent. And that's because of the anatomy. Where we give the high Gaugates is this area up here, where it's volumetrically a large area, and there's a lot of lipid, which is good for dissipation of our anesthetic solution. With our conventional IA technique, it's volumetrically a very small area with very little lipid, which means that our large bolus of anesthetic is going to sit exactly where we dropped it. And that might be part of why we see nerve injury. Now, I think it's important to understand that, again, complications can occur. It doesn't mean that you did anything wrong, but we're in a litigious society. You got to know that. And it's not just exclusive to California. So, I think the smart thing is to think about what's your risk, what's the benefit of the agent that you're using combined with the technique that you're using, what's the safest way to go. In my personal opinion, and it's only an opinion, is that I try not to use 4% anesthetics with a conventional IA technique. And I do find for some patients, the 4% do work better, particularly those patients, history of drug abuse, or they drink a lot of coffee, they're heavy smokers, stuff like this. They're hard to get numb, hard to keep numb. I like using these 4% solutions for blocks, but I'll use the Gaugates block rather than a conventional IA. All right, so here's my armamentarium. This is my last really meaningful slide here. So I like lidocaine with 1 to 100,000 epi for blocks, and I love articaine for all my infiltrations, okay? I keep a little bupivacaine plain on hand for when I don't want to use a vasoconstrictor, a little bit of long-acting anesthetic on hand when I want prolonged pain control for extractions or whatever, a little bit of buffering agent, a little bit of Oraverse. That's my armamentarium of the agents, okay? So let's wrap this up. Again, anatomy, physiology, technical errors are the big reasons, I think, for most of our failures. But think about local anesthesia. It's just like dentures. Dentures are not one size fits everybody. Local anesthesia is not one agent, one technique is going to fit everybody either. We need to be more thoughtful about that. Adequate anesthesia to ensure patient comfort for the duration of the procedure. Well, how long is the procedure going to last? How invasive is it going to be? And what's the nature of the patient? If you've got a real wimp for a patient, you might need a little different technique or a little more anesthesia. It's going to all depend on the patient. So we need to have different techniques. We need to have backups. The hammer is tempting, but the hammer is not a good practice builder. All right. So as practitioners, we need to be both physically and mentally prepared for the situation that we're going into. We need to think carefully about what we're telling the patient. I never tell a patient they won't feel an injection. I tell them that I'm doing all these things so that they won't feel the injection as much. If they don't feel it at all, I look great. If they feel it a little bit, well, I told them they'd feel it a little bit, so I still look good. All right. So to me, local anesthesia is a thought process that you need to think about carefully what's best for the given situation, what's best for the given patient. And it's that thought that really counts to get your patient to open wide like this to where you can really do good quality dentistry. You have to gain the patient trust. You have to earn that smiley tooth on the bib. So think about what you're doing, make the right decisions. And I hope that I've given you some guidance to make good decisions this evening. So that's it. Ugh. I'm 2 minutes overtime on my hour and a half. I apologize. But if we have time for questions, I'm more than happy to take questions.
Thank you so much, Dr. Budenz. I have a couple of questions. They're actually not in our Q&A,
Okay.
like we hoped, but
Okay.
actually in our chat section. And I got to read them. Luckily, I think they might have gone away. Actually, I knew one of them. I knew the guy that asked it, but I'll give you a chance to answer it. I think I knew what the answer was. Why don't they buffer our products and our carpels before we get them?
Because the volatility of sodium bicarbonate, that buffering won't last. It has no shelf life once the anesthetic is buffered. So it's bad for the sodium bicarbonate. It also is bad for the shelf life of the anesthetic. So you want to buffer your anesthetic just immediately before you inject it. Not in the morning before you go through the whole day, just before you inject it.
Great. Our other question, and I know the answer, I didn't get this back to, I didn't text this person, but do you aspirate when you do lingual infiltrations?
I do. I aspirate on all my injections just to make sure I'm not in a blood vessel.
Stay safe. Thanks again to our speaker, and enjoy the rest of your evening.
Thanks, everybody. Appreciate it. Good night.